Hello everyone, we are going to discuss about the chronic liver disease history and examination part in this video. So let us start. So cirrhosis, what is the definition? So cirrhosis is defined as fibrosis of the liver surrounded by regenerating nodules causing distortion of the liver architecture, right? So let us try to understand this by the pathogenesis of NASH, that is non-alcoholic steatohepatitis. So this is a healthy liver, right? So what happens is in NASH we know there is insulin resistance. So there is increased lipolysis of fat causing increase in free fatty acids in the blood. Now these free fatty acids get deposited as triglycerides in the liver causing steatosis, that is non-alcoholic fatty liver. Now this fat will ultimately undergo lipid peroxidation to cause inflammation, and this is known as steatohepatitis. Now this chronic inflammation will stimulate stellate cells, which stellate cells will cause fibrosis surrounded by these regenerating nodules, and this is causing distortion of the liver architecture that is known as cirrhosis of liver. So be it any etiology, whether it is alcoholic related CLD, whether it is non-alcoholic related CLD, all of them progresses through three stages to ultimately cause cirrhosis of liver. So as we all know that this is a dynamic process, right? So now what are the causes of cirrhosis? So broadly there are five important causes. Number one is alcoholic related CLD. Number two is chronic viral hepatitis, that is hepatitis B and C. Number three is autoimmune hepatitis, that includes primary biliary cholangitis, primary sclerosing cholangitis, and autoimmune cholangiopathy as well. Number four is non-alcoholic steatohepatitis, that is nowadays also known as MESALD, metabolism associated steatosis liver disease, right? Number five is metabolic liver disease, that includes hemochromatosis, Wilson's disease, and alpha-1 antitrypsin deficiency. Apart from that, there are other causes like cardiac cirrhosis and cryptogenic cirrhosis as well, right? So now let us talk about what are the clinical features of a patient presenting to us with chronic liver disease. So usually there are non-specific symptoms like nausea and vomiting, anorexia, malaise, vague upper quadrant pain, that is because of the stretching of the Gleason's capsule, and fatigue. Now, fatigue is the most common symptom in patients with chronic liver disease, and it is usually a afternoon fatigue, right? So it is usually not present at rest and is present after exercise or after activity. So therefore, it is known as an afternoon fatigue. Apart from these non-specific symptoms, patients can also present with specific symptoms like yellowish discoloration of the eyes, skin, or urine. Or the patient can directly present with complications like ascites, splenomegaly, varices, which are portal hypertension related complications, or there could be hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, coagulopathy, or malnutrition, right? We'll discuss all these complications one by one, right? So let us go on to the history of a patient presenting with cirrhosis, right? So abdominal distension is usually the most common chief complaint with which the patient presents. So be it any chief complaint, we should also always describe a chief complaint in the following five headings, right? Onset, duration, progression, aggravating factors, and relieving factors. For example, patient had abdominal distension for last 1 month, which was insidious in onset, gradually progressed over last 1 month to cause breathlessness on lying down, and it got relieved after taking some oral medications, after which patient reported passing increased amount of urine, right? This is how you can describe this chief complaint. After describing this chief complaint, we have to localize that whether this abdominal distension is because of congestive heart failure, because of nephrotic syndrome, because of anemia, or because of a chronic liver disease, right? So we should ask about the associated history of reduced urine output, frothy urine, blood in urine for nephrotic syndrome, history of chest pain, shortness of breath, palpitations, breathlessness on lying down, paroxysmal nocturnal dyspnea for congestive heart failure, right? History of weakness, lethargy, easy fatigability, chronic diarrhea, or difficulty in flushing of the stools for anemia and malabsorption syndromes. History of fever, weight loss, night sweats, abdominal pain for tuberculosis, tumors, and abdominal tumors, and pancreatitis, right? And history of yellowish discoloration of skin, eyes, urine for chronic liver disease. After localizing that, yes, this abdominal distension is because of a chronic liver disease, we'll ask about the history of the five common etiologies, right? Like history of multiple sexual partners, IV drug abuse, blood transfusion history, men having sex with men, or a high risk occupation like truck drivers, right? History of diabetes, hypertension, obesity for non-alcohol steatohepatitis, history of alcohol intake, then family history of jaundice, history of abnormal body movements or neuropsychiatric manifestations for Wilson's disease, right? Then history of drug intake, So drug intake usually causes acute liver failure, but yes, we should ask here also, right? So we should ask about all the possible etiologies to localize that what is the possible etiology of CLD in our case. And finally, we should also ask about histories of complications to see, to diagnose from the history that what our complications are present in this patient, right? Like history of altered behavior, altered sleep-wake cycle to look for hepatic encephalopathy, history of black tarry stools, blood in vomitus for esophageal varices, history of reduced urine output for hepatorenal syndrome, history of shortness of breath on sitting, that is platypnea, that is seen in hepatopulmonary syndrome, and history of bleeding from any natural orifice, that is for coagulopathy, right? So this is how you will describe a chief complaint of abdominal distension. Then similarly, yellowish discoloration of skin, eyes or urine, you should also describe in those 5 headings. Apart from that, we should also see the color of urine and stool, right? Because we know that clay colored stools are usually present in post hepatic causes of jaundice, right? And also we should look for, like in pre-hepatic, it is usually because of hemolytic anemia, so we should ask about the associated complaints of anemia again. In post-hepatic, there can be a possible cause of, for example, malignancy of the pancreatic head. So there can be a waxing waning course of the jaundice. There could be blood in stools, right? So all these associated complaints also we can describe in yellowish discoloration of the skin, eyes or urine, right? So this is how you will describe your chief complaints in detail. Once you have localized the history, once you have done the history, you will go on to a general examination. Now this is a very important part, the head to toe examination in a patient with CLD, right? Because there are many specific signs of CLD in a head to toe examination that includes icterus, spider nevi, gynecomastia or breast atrophy in women, spider nevi, right? Leukonychia, Palmer erythema, right? So we'll discuss all of them one by one in detail, right? So first of all, we should know that what are the estrogen dependent signs in a CLD patient, right? So these are the 5 important signs: spider nevi, Palmer erythema, gynecomastia, testicular atrophy, and loss of axillary and pubic hair, which are estrogen dependent signs. And the mechanism is that androstenedione is not cleared by the liver, and therefore it goes to the periphery and gets converted to estrogen, right? So this is the mechanism behind the appearance of these 5 signs in a patient with CLD. So when we talk about these individual signs, apart from the mechanism, the other important thing we should know about these signs are that what are the causes apart from cirrhosis causing these signs, right? So like spider nevi, apart from cirrhosis, can also appear in viral hepatitis transiently in women, because women have a estrogenic state, third trimester of pregnancy, estrogen patients on estrogen therapy, and in thyrotoxicosis. So this is a spider nevi, which consists of a dilated arteriole surrounded by multiple branching small vessels, right? And if you place a glass slide over it, it will blanch. And once you remove the glass slide, it will again fill from center towards the periphery. And this is classically seen in superior vena cava distribution, that is upper part of the chest, upper part of the back, and in upper limbs, right? So this is all about spider nevi that you need to know. Now coming to Palmer erythema. So this is a picture from Harrison. So Palmer erythema in occasion in patients of cirrhosis has a central pallor and surrounded by redness of the palms, right? So this is very classical of Palmer erythema in cirrhosis. Again, the proposed mechanism is a hyperestrogenic state, right? And the other causes apart from cirrhosis could be the same as that of spider nevi plus polycythemia and chronic leukemia as well, right? So all of these conditions can present with Palmer erythema. Now coming on to gynecomastia. So what is gynecomastia? Gynecomastia is proliferation of the fibroblastic stroma and ducts, right? Versus pseudogynecomastia, which is actually accumulation of just fat known as lipomastia. So now again, what are the causes apart from cirrhosis which can cause gynecomastia? So gynecomastia can arise from conditions like Klinefelter syndrome, which is an XXY condition, right? Then in tuberculosis, bronchogenic carcinoma, lepromatous leprosy, estrogen secreting tumors of the testis, drugs like digoxin, cimetidine, spironolactone, estrogens, right? All of them can cause gynecomastia. And finally, endocrine conditions like hyperprolactinemia, hyperthyroidism can also present with gynecomastia. So all these other causes of gynecomastia you should also remember, right? Because it can come as a separate short case as well. Now coming on to leukonychia. This is again an important finding in the head-to-toe examination of a patient with CLD. So leukonychia is white nails. So it is again seen in cirrhosis of liver. Apart from that, it is a marker of hypoalbuminemia. So apart from cirrhosis, it can also be seen in patients with protein energy malnutrition and patients having excessive loss of albumin, either from the intestine, that is protein losing enteropathy, or in the urine, that is nephrotic syndrome. Right. Now, there are three alcohol specific signs in head to toe examination of a CLD patient. That is Dupuytren's contracture, that is contraction of the palmar fascia, bilateral parotid swelling, and testicular atrophy. Right. So, Dupuytren, first of all, parotid swelling. So, specific sign of alcohol related cirrhosis. Parotid swelling can also be present in mumps, and infiltrative conditions like sarcoid, Sjogren syndrome, amyloid, leukemias, lymphomas, parotid tumors, or parotid duct stones, right? So these are other conditions of bilateral parotid swelling. In Dupuytren's contracture, again alcohol related cirrhosis, it is specific for that. Apart from that, it can be present in a familial way as an autosomal dominant inheritance. It can also occur in conditions causing microvascular abnormalities like HIV, diabetes, smoking, dyslipidemia, right? And finally, the third condition, which is alcohol-specific CLD, seen in alcohol-related cirrhosis, is testicular atrophy. And apart from alcohol-related cirrhosis, it can also be seen in mumps, lepromatous leprosy, and trauma. So, in all these individual signs, what we need to know is number one, mechanism. Number two, the other causes apart from cirrhosis, where we can see this, right? So this is very important to know in head-to-toe examination of CLD. Now, once after taking the history and examination, abdominal examination I'll demonstrate in a separate video. Now we know that after this history and examination that yes, this is a possibly chronic liver disease case. So the first investigation that we get done is a liver function test, right? So we'll see in the next video that how do we approach a liver function test, right? Thank you.